The other thing that we see patients for a lot is prolapse. And this is, again, something that occurs or starts with childbearing. And the ligaments of the pelvic floor that I showed you, they either get stretched or they get broken. And it can be alarming for patients. They'll feel a bulge when they're in the shower, or they'll notice a heaviness, a pressure sensation. They can have discomfort with intercourse. It can present in all kinds of ways. But my first message to patients is prolapse is a type of hernia. That's what it is. It's not cancer. It's not life-threatening. It's a type of hernia. And the important thing with that is they're the arbiter of this issue. So I have some patients that come in, they have a little prolapse. We kick back our chair and talk about it, and it's something they decide not to do anything about. And that's their choice. It may not be bothering them that much at that point in their life. But when it gets to the point where it's bothersome, it's preventing them from playing pickleball or having relations with their husband or what have you, when that time comes and they're to the point where they want to get it fixed, the beautiful thing is that we can design the surgery and customize it to the defects that are there, and we can restore that normal anatomy. And we do that through little incisions. Typically, surgeons will use different techniques. I use a robot, and I find that allows me to be much more meticulous and exacting in terms of restoring that normal anatomy. And when we restore that normal anatomy, their function returns, and they're able to return to a totally normal life. Some of them need to have some of these nerve issues addressed because that's a separate issue. But again, we've got these tools now that are available to help in that regard. Prolapse is a type of hernia. And I think you can see from this model, this muscle here really represents the pelvic floor. On the inside, if you look, I don't know how well you can see it, but these white lines are ligaments. And they're strong ligaments, but with childbearing, they are broken. And I'm just going to give you one example of how we can customize and fix this really in a minimally invasive way. In a high percentage of women who develop what we call a cystocele, and a cystocele is a herniation of the bladder. I've taken the bladder out for purposes of demonstrating this. The white line that's attached to the inside of the pelvis breaks away, so it's flopping in the breeze. And then because of that bladder just sinks. It sinks into the vaginal canal with coughing or sneezing or bearing down. And I'm able to go in through little incisions robotically, open this space up, and I can hand sew that. I can reattach that ligament to its attachment, and that restores the normal anatomy. Our goal is to restore that normal anatomy, and understanding that it's a hernia and knowing where that hernia or hernias, sometimes there's more than one, where they're occurring, that's the key to establishing that normal anatomy. But you'll hear terms like cystocele. A cystocele is where the bladder is herniating into the vaginal canal. Erectocele is where the rectum is herniating into the vaginal canal. You can have uterine or cervical prolapse. That's really where the defect is up at the cervix, and those ligaments around the cervix have been broken, and so you get descent of the uterus cervix into the vaginal canal. Those are all types of hernias, and we can approach each of those individually, and we can restore the normal anatomy at each of those places, and again make it so that things are like they were prior to childbearing.